Okay, you've been playing sports and you feel you've had a serious injury to your knee. You have significant pain and or swelling in your knee, and your knee may feel unstable. There's a process to evaluate exactly what has happened with your knee and determine a correct diagnosis. First, you need to see a qualified orthopedist or physical therapist, and they will do some objective evaluations to test your knee, to check the integrity. And then Rob Mangini, our friend with University Imaging, is here, and he will discuss some of the pictures they take with the MRI technology to take a more definitive picture of the soft tissue structures.
This, as you can see here, would be Wood's non-operative knee, or actually his good knee, where you can see the ACL band is attached to the femur and to the tibia. This other shot is of his injured knee, and you can see the anterior cruciate ligament is torn with that sag in the middle. It's not a tight tendon from the back of the femur to the front of the tibia.
The ACL primarily keeps the tibia, the lower leg bone, from translating forward on the femur, the upper leg bone. And one test you can do, it's called the Lockman's test. You have the patient relax, and you're checking for how much translation you get in the knee, how far forward that tibia moves. And if you get a good solid feeling, it's kind of like a rope, like Rob was showing in the pictures, if it stops the knee. You can also do an anterior drawer. We have the patient bend their knee a little bit, and again, just keep their foot from moving, get their hamstrings to relax, and again, check for that translation to see if there is any instability in the knee itself.
What we're actually going to speak of today is more of the treatment options, as Mitch had alluded to earlier, with actually the reconstruction side of the ACL. There's two different options that your orthopedic surgeon will choose. One is an allograft, which is a cadaveric graft, and the other is an autograft, which is they harvest the tendon from the patient. An autograft is a patellar tendon autograft is something they would take from the patient and actually take the central third of the patellar tendon. All of that wound site would heal through the healing process of the whole recovery process with the patient. The other option is the surgeon might take the patient's hamstring, and there's different surgical techniques in order for the surgeon to reconstruct that ACL. An allograft, or the donor graft, it's actually going to save the patient some pain. Some of the downside of it is that patient, when they actually make that choice with their orthopedic surgeon, they're going to have to listen to that surgeon unequivocally throughout the rehabilitation process. The patients aren't going to hurt as much, but there's the success rate over the last X amount of years have been fantastic.
Once a patient has undergone ACL reconstruction, they come into physical therapy, and the first 2 to 4 weeks of rehabilitation, our goals are to decrease the swelling in the knee, to help regain range of motion, both flexion and extension, with extension being the more important goal, and then also advance the person into a weight-bearing status. In order to control swelling, what we'll use is different modalities such as electrical stimulation, ultrasound, as well as some hands-on massage. As far as regaining range of motion, we'll have the patient do exercises such as heel slides, where they slide the heel towards their butt and straighten the leg back out again, doing that numerous times for the range of motion. And then to start building up strength and lead towards weight bearing, we'll have them do straight leg raises, where they contract the quad, lift the leg up and down, and then progressing into some weight bearing activity. We've talked about, for the first 4 weeks of rehabilitation after ACL reconstruction. Now we're going to touch a little bit on from approximately week 4 until week 12. I have Rob with me, and Rob's going to give us a little information regarding the integrity of that graft during that period of time.
Some of the toughest part of the rehabilitation process is actually this time frame of what we're talking about. The graft itself, and the science behind the graft, is that the graft is at its weakest point when it's trying to refixate amongst the femur and the tibia on the patient.
Yeah, so what the body has a tendency to do during this period of time, from about the 68-week period, is it starts to reject the graft. And so that graft loses a lot of its tensile strength and integrity, and patients are at a great risk of re-injuring or tearing that graft.
Absolutely.
I don't know if you've seen that often or not.
I have seen that. Patients don't hurt as bad during that time, so they're thinking, hey, I'm great. My doctor doesn't know how I feel.
Right.
My therapist doesn't know how I feel. It's time to get out and start being active again. They've been cooped up in a gym in the whole rehab process. The long and short of it is you want to listen to your rehab specialist along with your orthopedic surgeon during this entire process to get a great result.
All right, we're in stage 3 now. We're 4 months post-op from ACL. And now you can start progressing with some more dynamic type of movements, like Sean is doing some lateral type of loading here. Dan here is going to do something, get his legs a little stronger, a little more quick twitch, driving that sled down and back. You can progress to things like skip, lunges, those kind of things. But now that you're 4 months post-op, you can start getting more aggressive. Our objective is to be doing a lot of the sport activities at 6 months.